Good afternoon. This is Dr. Dan Guerra coming to you from Authentic Biochemistry Studios on the 13th of March, 2022. We are going to do a synthesis of diabetes, and that's why I'm doing this video lecture. You normally hear me on the only audio Authentic Biochemistry podcast, but as you know, I occasionally do videos, and I usually post them on YouTube. Probably will do that and probably find other platforms as well as time avails. So let's go right to the lecture. All right. So as I said, we're going to do a synthesis of a discussion of diabetes. Remember, we're doing this arc of lectures of specific things that intrigue me and also intrigue some of the viewers and listeners. And that's how the topics are generated. If you have a topic you'd like me to cover, send me something in the comments section of this YouTube video, or go over onto my Authentic Biochemistry podcast, leave a message there. Comments are always grateful, and I will consider topics that you may ask for. Anything that's in biomedicine that is associated with biochemistry, I'm glad to be able to look into for you. Remember, I look at primary scientific research literature, peer-reviewed, and I discuss it in this sort of lecture discussion format. I would very much like to be able to have it be interactive, and we can look into that. I've been trying to look into it for some time. I'd like to be able to get an audience large enough to be able to break out into study sections and study groups so we can actually do some serious learning on given topics. I spent over a year doing aging as a very large topic because most people are interested in it, right? Because everyone is aging. And that's all free. And really all these YouTube videos and podcasts I do, the audio podcasts, are also free. But your professor here could certainly use some help in organizing for the content and then writing these lectures and then producing these authentic biochemistry videos and podcasts. As you might guess, it takes a lot of time to do this, and time is valuable, and times are hard. So I don't think I need to explain any better than that. So please donate on either the YouTube channel or directly here on the YouTube channel. I think Patreon can be connected to it. I think it is. But on the podcast, you can just donate directly by subscribing. So please do that, because then I can get this content to you in more vivid detail than you already are getting. So I don't have to have a second job like cutting wood. Okay. Anyway, let's hide this bar and let's get it to our lecture. All right. Here's a paper that was published in JAMA. You can see it was published rather late in 2021, so it's not very old. And what's it say? It says the prevalence of type 2 diabetes, T2D, is of course risen in the population, and that aging is a component of it, but also increasing obesity, which has become a pandemic worldwide, and with that, physical inactivity and energy-dense diets all have come together to increase the amount of type 2 diabetes in the general population, where it's become a very, very dangerous disease. In fact, more than 90% of individuals with diabetes have type 2. And among those, there are considerable potential for disease management, which, of course, is being done with pharmacotherapy, but also with dietary restriction, and also sometimes with surgery. And this management is directed towards reducing the risk of subsequent health complications from type 2 diabetes, which can include high morbidity and mortality. As we'll see, various spectrum of disease states. Diabetes is associated, for example, with a higher risk of cardiovascular disease, along with mortality from non-vascular conditions. Okay. Younger the age, a type 2 diabetes onset or a diagnosis is always associated with dementia and earlier mortality, especially when there is cardiovascular involvement. All-cause mortality risk factors in either early, that's less than 45 years, mid 45 to 65, and late life, greater than 65, diabetes is judged to be a major risk factor only in late life. And that's associated with a population attributable fraction of about a little over 1%. Okay. So this comes directly from his papers. You can see, because you can still see some of the citations in there. Right. Now, the younger age at onset of diabetes, if we're talking T2D now, is significantly associated with a higher hazards ratio of dementia. So the data spanning 35 to 75 years for age of diabetes onset actually showed every 5-year earlier onset of T2D was significantly associated with higher hazard of dementia. Late onset diabetes was not significantly associated with subsequent dementia. So if a person becomes obese, which is usually highly correlated with T2D, say they didn't become obese until they were 65 or 70, then the chances of dementia developing from that population, as opposed to the general population after 65, is not going to be that significantly different. So we're talking about the fact that chronic obesity at an earlier age, and you know it's dipping way down into the teens now, will bring earlier onset dementia, not otherwise associated directly with, say, Alzheimer's, but can be, but just dementia, which is, of course, a neuropsychological disorder, is going to occur earlier and will become of higher morbidity and will contribute to higher mortality the earlier the onset of obesity with type 2 diabetes. That's what it's saying. That's what the information is starting to distribute, tell us. So late onset diabetes was not, again, associated with subsequent dementia. That's a key feature. Means that earlier and longer, more chronic, that a person's obese and gets T2D, the more likely they're going to get dementia. Other key findings include the lack of a robust association of dementia with preclinical diabetes. This would be pre-diabetes or simply fasting glucose alterations, aberrations, right? Now, individuals with diabetes and with stroke comorbidity give an additional risk of dementia. And I think we can understand why, because you're getting lesions then in the central nervous system with stroke, right? So meta-analysis of an association between T2D and dementia reported a risk ratio of about 1.43 and 1.62 between those two. Now, we're going to talk about risk ratios and hazard ratios and explain them in a little more detail now. But basically, take two different, what should be, at least with a null hypothesis, independent variables, and you do a little bit of very simple mathematics, statistical analysis. And you find out that there is a risk if you have T2D and dementia. And the risk is in the order of, if you have obesity and T2D, you're going to be more likely to develop dementia. That's what that risk ratio means. Next, again, I'll show you the definition of it and how it's worked out. Now, in line with those results, okay, which are rather not good results, right? In the present study that we're looking at here, of a hazard ratio of when all diabetic cases were considered in the analysis, including those occurring after 70 years. Okay. So we're going to see that hazard ratios are going to be discussed, and also just a straightforward risk ratio. Okay. Again, I'm going to explain these things to you. Now, keep that in mind, put that in your mind, and now look at this. Nature Reviews paper published a couple years ago now, almost 3 years ago exactly. Obesity, of course, is an epidemic. It was then, it still is. 2 billion adults worldwide are considered obese or fat, according to the World Health Organization. That isn't enough to start keeping your eye setting at 6'1". Try adding over, that is only looking at the height of, like, for example, 6'1", like me. Over 40 million kids, 5 years and younger, have been added to that data, 2 billion. So obesity is happening at a much earlier age. Obvious links to the cardiovascular diseases and to non-alcoholic fatty liver disease, or NAFLD, lead, of course, can lead, not necessarily, but can lead. There is a metric to lead to hepatocellular carcinoma. So you got obesity, going to non-alcoholic fatty liver disease, going to a very, very deadly cancer, HCC. Okay. So there's a correlation. In fact, obesity is becoming the number one health-related physical abnormality, pathology, and it's dangerously increasing in children and in young adults up to college age and beyond. It's defined as having a BMI equal to or greater than 30 kilogram per meter squared. That's what obesity is defined at currently. And of course, it's correlated with a lot of things. Metabolic syndrome, which includes hypertension. That's one of the factors of metabolic syndrome. Type 2 diabetes, which we've been talking about a great deal in the audio lecture, so I don't need to remind you of all the different aspects of it. Okay, I'll tell you one: insulin resistance. What else is higher BMI associated with? Non-alcoholic fatty liver disease. That means fat deposits accumulating in the liver, in hepatocytes, and also in extrahepatic domains within the liver. Okay, we talked about that too, right? You also get this association with non-alcoholic steatohepatitis, which is moving from NAFLD through NASH to HCC. I can tell you because that's what the clinical research is showing. It's a major risk factor, having a high BMI, for several common types of cancer, most notably of which are solid organ, which are involved in digestion and in overall metabolic homeostasis, meaning a lot of lipid metabolism. The pancreatic and hepatic cancers, right front and center for all of that discussion, for central metabolic regulation of the entire organism, human. So there are some more lethal cancers with 5-year survival rates, the hepatocellular and the pancreatic ductal adenocarcinoma, of only 4 to 8%. In fact, HCC is the most common form of liver cancer. And I'm telling you, it's directly related to fatty deposits and also fibrosis in the liver. And they can include, there could be a factor associated with cirrhosis. So you don't rule that out. It's not measured away. Right? Connection between obesity, though, and cancer is mediated by a state of chronic, low-grade, yes, immune response-associated inflammation. And that's in any of the involved tissues: lung, liver, kidney, pancreas, brain, skeletal muscle, adipose, okay, cardiovascular. Some major ones you probably have thought about. Okay, now back to this JAMA paper. Okay, so a lot of detail here, a lot of writing that derived directly from this paper, so though that I can get to the synthesis. So please bear with me. That's what we do here. And of course, I'll put on the magic spectacles to allow me to read this with more precise surveillance. Again, a paper published late last year in JAMA. Population attributable fraction of 1.1% of diabetes in a recent Lancet, of course, that's a British journal commission, was based on a risk ratio of about 1.5 and prevalence of diabetes at 6.4%. Again, I'll explain to you about risk ratios and the mathematics behind it directly. Now, just follow along. You know, the risk ratio is looking at how diabetes and obesity are linked, right? And that the risk for getting diabetes is associated with that higher BMI, and that it's a risk factor for many other diseases. Okay. So the risk ratio and the prevalence of T2D may not be generalizable. It's always the case. Very, very dangerous to make that induction, right? You get hypothetical deductions where you have a general consideration and you ask the question, what is found in a general population, that is what is found in the research literature, is that going to accommodate what we're currently looking at in some subpopulation? So you deduce a hypothesis, and then you design an experiment for that series of experiments for that hypothesis. You generate data. The data is accumulated, assessed, weighted with some statistics, and developed into evidence. And then the evidence is discussed against the backdrop of the primary literature that's already been published. And then you make that induction. Okay, you see how that works in science. Not a straightforward thing either. It's always biased by people who have convictions in the scientific community about what they think their research says, and indeed what the corpus of the literature says in the plenum. So scientists are not just purely objective because there is no human that can operate that way. Scientists have their own biases, and this is not something that can be put into the calculation, into the metric of how the research is conducted or even what research is conducted, and that has to do with funding. Right? I've said this for years in open lecture at universities I've taught at, and I've conducted research at, and also for the last couple of years doing this online. Right? So I always want you to remember that. Myself, I have a bias too. I'm a lipid biochemist, and I've looked at obesity and lipid dyslipidemia and lipid metabolism now for, I guess it's about 40 years. And so I have my own biases about how I think there's the direct linkage. I won't say a cause, I'll say a direct linkage between obesity and many of the high morbidity, mortality diseases, including the chronic increase in rate of one disease known as aging. Yeah. One that is inevitable, by the way. All right. So risk ratio and prevalence of type 2 diabetes is now generalizable. I'm not sorry for that aside I just made. Hazard ratio of dementia for diabetes onset at or before the age of 60 in the present study was 1.99. That's a very high hazard ratio. Okay. The global prevalence of diabetes is estimated at 15% before ages 55 to 59 and 20% or greater once you reach 65. In the UK, the prevalence was about 19.3% in 2014, 2015 when the study was, when these values were calculated, right? The statistics were done. The results of the present study, the one we're looking at now, the JAMA paper, is going to suggest that a population attributable fraction of 1.1 is likely to be an underestimate, particularly in settings where the prevalence of early onset type 2 diabetes is high. That means that fraction simple of 1.1 is probably going to be a higher correlation, if you want to put it that way, between obesity, diabetes on one hand, which go together, which organize together, they fractionate off to one side, and central nervous system dementia diagnosed. Okay, that's what they're saying. Now, studies that explicitly consider age at diabetes onset or diabetes duration, and usually when a person gets T2D, the duration is to the end, right? Very seldom do people actually become, quote, cured, unquote, of type 2 diabetes. It's a chronic disease. with multiple factors and multiple variances on those factors, and that multiply over time because of aging. And that very seldom would you ever say this person is disease free, even if you're looking at indicators as large of metric as insulin resistance or circulating glucose, okay, which are only biomarkers, I should say, because the number one association of diabetes is dyslipidemia. And of that, you've got to look at all the different subfractions of all the lipoproteins. You have to start getting inside those lipoproteins, looking at molecular species of lipids and molecular species of proteins, apolipoproteins. And beyond that, you have to look at the trafficking of lipoproteins, the movement into and out, for example, immune cells like macrophages or T lymphocytes. That's correct. Lipoproteins can be taken up by such cells, and what effect that has on the immune response. Right? These are all factors which could be bulked together into something called dyslipidemia. And I've been talking a lot about it in these lectures, so I don't feel that I should refrain from bringing this up as a general, a priori synthetic bit of knowledge, because you should already know this if you've been following along on the podcast, as I'm sure you do. All right. So we've got all that. Now, there's one exception is the Swedish twin registry study, in which record of diabetes before 65 years old. Now, that's going to give an odds ratio of 2.41 with a 95% confidence interval, but not after 65. Look at that odds ratio. I'll drop down now to 0.68, still the same CI, was associated with a higher risk of dementia. So that was a twin study, identical twin study in Sweden. Now, results from the US ARIC study, based on persons aged between 66 and 90, at start of follow-up, suggests longer diabetes duration to be associated with higher risk of dementia, only in the youngest age tertile. Tertile is just a statistical term I'm sure most of you are aware of. Longer duration of diabetes has also been associated with a faster cognitive decline. So not only are you likely to get dementia earlier with type 2 diabetes as a risk factor, but the rate of decline in cognition and emotional state, which combined make up the factorial for dementia, the rate increases. The earlier one is high BMI, obese, and T2D defined after diagnosis. So careful analysis, the age of diabetes onset, the present study, along with explicit examination. So this paper was done with a good clinical paper in JAMA, showed a graded association between age and onset of diabetes and the risk of dementia, all form. Results from previous studies on pre-diabetics and dementia are inconsistent, as I said a few minutes ago. And a meta-analysis found associations with increment dementia. Now, these are the risk ratio 1.18. Again, high confidence interval or classic, 95%, but not cognitive impairment. Now, incident dementia is unique compared to cognitive impairment. And, again, I think you don't need to go very far to get examples of this, okay? Now there, the risk ratio is 0.96. It's a little bit lower than unity than the incident dementia. Now, another study on fasting glucose, which of course is a biomarker for type 2 diabetes, in adults older than 65 years without diabetes, found higher average rather than fasting glucose levels within the preceding 5 years, to be related to a higher risk of dementia. Again, the hazard ratio is above unity, 1.18. Okay, and the amount of glucose that we're talking about is 115 milligram per deciliter compared to 99. So it's a very tight margin. Right? So the present study did not show when we're talking about a robust evidence of an association between the pre-diabetic state, that narrow window there, right, between 99 and 115 milligram per deciliter of circulating glucose. And that's only a biomarker. Understand, that isn't the entire disease spectrum by any means. So glucose levels can be controlled, and yet a person still has what I would call classical, clinical type 2 diabetes, just not with the glucose factored in. That can happen because type 2 diabetes and even type 1 diabetes are really dyslipidemias. They're not just a lack of control over serum glucose. So if you use that only as your marker, you're not really looking at what this disease and its complications are. Okay, not just associated with, but what that really is. Okay, that really important point when you think about what's discussed in papers, published papers. Okay. So fasting blood glucose in those without diabetes has been shown to be only modestly associated with risk of vascular disease. Okay, so that means that when you do a glucose tolerance test, if you go into a clinic and you get a glucose tolerance test, they give you some sugar, orange juice, for example, and then they want to measure the amount of glucose in your blood. They sample it, a couple of times if it's done well, and they look at the clearance of glucose. Now that indicates how potent your insulin, not only synthesis, secretion, but also its reception in major organ systems like the skeletal muscle and the adipose is functioning. Okay. But simply looking at that fasting glucose is just not sufficient to be able to clearly look at all the sequelae that is type 2 diabetes. That is the pathobiochemical sequelae, and then linking that to the pathophysiology. Okay. That's what the literature tells us. Right? That's not just my opinion. Now, there's a certain threshold of high glucose levels that's probably necessary for what can be called hyperglycemia associated brain injury, because high levels of glucose will corrupt central nervous system. For one thing, it will alter the kinds of biofuel used to generate ATP. Of course, the differences between using pure glucose or high levels of glucose versus some beta oxidation of fatty acids, and then generating ketone bodies. For example, that was the microglia to neuron shuttle I talked about a few months ago, or indeed protein breakdown and amino acids to generate via transamination reactions carbon sources for the TCA cycle to make the reduced NAD and the reduced FAD to run the electron transport chain to generate ATP. 3 different biofuels: amino acids from protein, carbohydrates, primarily glucose, and then fatty acids. Right? All of those are only indirectly linked to hyperglycemia. So hyperglycemia is just measuring glucose levels in serum. Right? A lot more to it than that. All right, now let's move on. Now here's the biostatistics that I want to discuss. I know that I've written a lot here, and it comes directly from this paper. Again, this paper was published in 2011. Okay. Hazards ratio are used to estimate the treatment effect for time to event endpoints, such as overall survival, so they call it OS, and another very important metric, PFS, which is progression-free survival. So HR is used for both OS and PFS. Okay. And that's done typically in oncology studies, but it can also be done with neuropsychiatric disorders such as dementia. Okay. And of course, you study this with RCTs, randomized controlled trials. Now, a lot of work is done preclinical in animal models, mouse and rat, right? The murine model of the mouse is really well respected for studying metabolic diseases. Not so well respected, at least from my point of view, for neuropsychiatric disorders. As you might guess, why. All right. Now, a time to event analysis also, and from the point on this point on, called a survival analysis, looks at the time from a start of a study. For example, the start is usually randomization. So you've got different cohorts of people that you found come together. They're all obese, for example, or they all have type 2 diabetes. And then you randomize them for different kinds of treatments, for example. And then you look at some endpoint event, death, for example, for overall survival, or maybe progression-free survival if you're looking at their blood and measuring multiple biochemical components. Okay. So now there's the Kaplan-Meier, the KM curve. That's also known simply as the survival curve in cancer. And it's used to estimate survival, and it presents, of course, survival data. The curve represents the population of patients event-free. That is, for example, alive for the overall survival, okay, at any time. The curve is never smooth, but it actually demonstrates a series of downward steps occurring each time a patient has an event. For example, a death. Excuse me for 1 minute. I have to take care of my dog. He needs to go outside, and he thinks he's going to chase deer. Okay. He won't, but I'll be right back. There we go. Sorry for that. Hopefully you were reading along as I was gone. Yes, indeed. The producer, the director, the content maker, and of course, the person who's delivering all of this is the same, one and the same. That's me. So I do this all on my own, and I'm doing it in my own studio. So that's why I had to get up. And I don't make any apologies because, as I said, times are hard. Times are hard. All right, so let's go back to the Kaplan-Meier curve. Told you that has to do with overall survival, okay? And the curve isn't smooth, obviously, according to time, right? So people that are first diagnosed with cancer, maybe in stage 1, stage 2, say a non-small cell lung carcinoma, there might be a long period of time, especially with pharmacotherapy, where there's no progression. And so the survival is going to remain at a stable plateau for a long time within the population. And then because of aging or new comorbidities coming on board because of the disease itself or other linkages with comorbidities associated with obesity, type 2 diabetes, that can spike, and you'll get then more people falling off the Kaplan-Meier curve because more people will succumb to their disease. You understand? So it is not a smooth transition because biological systems don't fit smooth curves, right? And never believe that they do. There is no real causation in any of this. It's just correlation, right? And sometimes the correlation is really good, and sometimes it's not so good. And with statistics, it can be made to look linear or curvilinear. But again, that statistics playing a role there, right? Individual biological patients, right, are going to vary according to some mean. And that variance is going to have to do with multiple components, including genetics and epigenetics, as well as those confounders like aging and comorbidities. So That's all that's saying. Now, at any time point in an overall survival analysis, patients can have only one of the following events. So this is, again, if you follow through now, people that already know this, this is just a refresher for you, but many people that watch these lectures I do don't have all this information. So death is one, continue to be monitored is two, because that doesn't always proceed, or stop being monitored, and they call that being censored, just a term that's used. Okay, it doesn't mean the same thing as a colloquial term. Patients who are quote unquote censored have not had an event as of the end of the observation period, because obviously they're not being observed all the time, right? Until they grow old, for example, and die. And it is unknown whether they will have an event in the future. So that means they can't be used in the OS statistic because you don't know what's going to happen or play out with them. So that whole data set has to be removed from the population. That's what it's saying. Several reasons for censoring. This is what censoring means, removing them from the overall population dynamic, what you're measuring. Typically, it's because the patients are still alive, which is, of course, a good thing for them at the end of the study, or they're lost to follow-up. They just move, or they're no longer interested in contributing to the study. And then you get a fair amount of people dropping off, particularly if they feel better. For one thing, the pharmacotherapy could have been diminished. If you think about something like chemotherapy, they're no longer on chemo, or they're no longer on any immunologics, they may not be interested in coming into the hospital and getting their blood drawn, or whatever other kind of measurements are being made. You understand? Okay. All right, now, an HR, hazards ratio, provides an estimate of a ratio of the hazard rates between the experimental group and a control group. An experimental group would be someone, for example, on, program death ligand or something like that, right? Somebody that's on an immunologic would be an experimental treatment, or somebody that's on chemotherapy, right? Cisplatin, various kinds of traditional chemotherapeutics for depending on what kind of cancer you have, right? Would be first line, second line, third line level treatments, right? And often these treatments are more robust if you have more than one pharmacotherapeutic event being used. And there's also radiation therapy that's associated, and sometimes also surgery, right? So all these things contribute to that metric. So where was I here? So control group over the entire study. Hazard rate is the rate of patients experiencing the event, whatever it is, death, for example, of interest over a short time interval within each of the treatment arms of the study. And it's going to be multiple treatment arms. There's going to be different rates of a pharmacotherapeutic. There's going to be different time points when that therapeutic is given. And there's going to be all these different co-associated pharmacological, as also I said, radiological and resection therapies that will come and go in a given patient's treatment profile. Right? So that's what all that means, different treatment arms. This concept can be illustrated by a hypothetical example, which I'm going to give you here. Again, it's all from this paper. So you have a randomized controlled trial with two treatment arms. That's very simple. And the primary endpoint of OS, right? That's overall survival. Remember, overall survival. Pretty clear how you measure that. Right? Now, during the first week, the rate of patients dying is higher in the control arm. Say it's 0.04 than the experimental arm, 0.03. Okay. The second week, the rate of patients dying is double than in the first week. So it goes from 0.04 to 0.08 for patients in the control arm, and it goes up to 0.06, which is also a doubling for patients in the experimental arm, right? Given the pharmacotherapeutic, for example, right? So the hazards ratio, which is just a ratio of experimental versus the control here, is calculated for each week by dividing the rate of patients dying, succumbing to death, right? Overall survival. In the experimental arm, dividing that by the rate of patients dying in the control arm. And although the hazard rate changes over time, the hazard rate here is approximately constant for each week, right? Because it's 0.3, right, divided by 0.4 at the beginning, or 0.6, 0.06, 0.03 divided by 0.04, that's 75, about 0.75. And it's the same if you're taking 0.06 and dividing that by 0.08 for the control arm. It still remains an HR of approximately 0.75 for each week. Right? Hence, the hazard ratio reported for that particular pseudo randomized controlled trial would be 0.75 because it's a constant HR and it's going to be calculated over the entire duration of the trial. And it can because it's consistent over the duration. You see how high hazard ratio works. Hopefully that was pretty straightforward. Again, that's directly from this paper. Now, let's move on. During the first week, the rate of patients dying is higher in the control arm than in the experimental arm, as we just saw. Second week, the rate of patients dying is double than that in the first week, 0.08 for patients in the control arm, and 0.06 again for the ones getting the treatment. So the experimental versus control is calculated for each week by dividing. And even though the hazard rate changes over time, the hazard ratio is approximately constant for each week. So this is, again, the take-home message, okay? I just rewrote that for you and bolded it out to get the idea. So there's no asymmetry in your understanding, therefore there should be no misunderstanding. So this could be shown in this slide here. Again, this comes from this 2011 paper. So here's a ratio of 1 to 1, right? If it's 1, if it's unity, it means there's no difference between the control or the experimental treatment. Looking at a hazards ratio where it's derived from looking at experimental versus control, if you get a lower number than 1, it means it favors the experimental treatment. So the pharmacotherapy is working, for example. If it's higher than 1, it means that it's not good taking this treatment, because if you don't take anything, or at least not that treatment, all other things being constant, it favors the control. So as the authors say, it's a simplistic interpretation of a hazards ratio, where HR equaling 1 means equal efficacy between the experimental and control. And therefore, if that's the case, you're not going to suggest the treatment, right? Now, if the experimental treatment is better than the control, then in this particular way of deriving the HR, where E versus C less than 1, then you know that the experimental treatment, the pharmacotherapy, right, the adjudged pharmacotherapy for this, artificial experiment would be less than 1 then, right? And that would mean that it would be a good idea to use that pharmacotherapeutic. If the experimental treatment is worse than the control, then the HR would be greater than 1. Okay, so I think that's clear how that is measured. Hopefully it is. Okay. Now, let's go back to this type 2D discussion. So I did a little bit of statistical discussion for you, right? We'll do more, but I don't want to overload it. It's biochemistry. This isn't biostatistics, or biometry, as we used to call it. So T2D is associated with higher risk for vascular diseases. Everyone knows this. So what's the connection to dementia, though? Right? For example, hypertension. How's hypertension linked to dementia? Right? So again, Swedish National Study on Aging, here you go again, the chronic disorder of aging that we all have, looked at the risk of dementia in participants with diabetes and any other cardiovascular comorbidity compared with a non-diabetic cohort. And what they found is that the higher risk among those with diabetes can't be attributed statistically to the cardiovascular comorbidity. Aha! So you can't say, well, because there's a comorbidity associated with diabetes, type 2 diabetes, that includes cardiovascular disease, including things like metabolic syndrome, cardiac hypertrophy, any number of cardiac and atherosclerotic conditions, which can derive from obesity and then on to type 2 diabetes, all putting them in the line together, because they often are. What they're saying is that entire contribution cannot be directly linked to heart or cardiovascular disease or cardiovascular heart conditions. Okay, so it's more than that. That's what it means. Okay? So stroke combined with diabetes. Now, of course, when you think stroke, once again, you're going to think about a major lesion in the CNS. Now, and with a heart, not necessarily unless you have a heart incident, right? Unless you have you have a heart attack or you have heart failure, right? So stroke combined with diabetes was associated with a higher risk of dementia. I think that also is very well described with people when they know anything about stroke and negative effects, long-term negative effects on motor and cognitive skills after a stroke. Right? And that includes dementia. And the highest risk dementia was seen in those with stroke, cardiovascular disease or cardiovascular heart disease, and within that, heart failure. Right? Heart failure just simply means you're not pumping enough blood, right? At some level. Consistent association between diabetes and the pathobiochemistry of AD, that's Alzheimer's disease, such as amyloid and tau pathology, was not that straightforward. Now, we spent a lot of time in video lecture and in audio lecture on Alzheimer's disease pathophysiology, including the tau and the beta amyloid. I probably have given, I would say conservatively, 30 hours of lectures on this. So I'm not going to cover it right now, but you know that tau and amyloid pathologies are always linked. Sometimes I think inappropriately, but always linked almost as a direct correlation with Alzheimer's disease and its level of intensity in terms of deficiencies in cognitive and motor skills. And what we're saying here is that stroke combined with diabetes was associated with higher risk of dementia, okay. And the highest risk was associated with stroke, CHD, and heart failure. Now, when you take that all together and you look at diabetes and pathobiochem as associated with tau and amyloid, for AD, they don't necessarily line up. Okay. What does that say? Simply, there's more involved. What's more involved? Dyslipidemia. You understand? Always, which is a very complex discussion, as you've noticed. So there's conjecture, perhaps central nervous system bioenergetics. Who hasn't talked about that? Not me. I talk a lot about bioenergetics, different biofuel for different bioenergetics, right? Immunology, I talk a lot about inflammation and dyslipidemia. There it is, right? All of those are known to drive alteration of bioenergetics, alterations in the immune response, usually with the co-inflammation. If it's in the CNS, you know what it's located to, the microglia, activation of the microglia, resident macrophages, and dyslipidemia, which can drive both alterations in bioenergetics and the inflammatory response. And I've covered that many times as well, right? T cell, B cell, leukocyte in general, intracellular biochemical pathways as affected by dyslipidemia. Boy, we have certainly covered that over the months and years. Okay. So all that lines up with an inefficient insulin transport, it can, right, through the BBB, blood-brain barrier, but also insulin resistance, that is the signaling once insulin binds to its receptor, right, that tyrosine kinase receptor, and then everything downstream from that, but also glucose insufficiency within the cell. If you have insulin resistance, you're not taking up glucose. If you're not taking up glucose, you have to have something for biofuel, and that could include fatty acid, if available, or also protein breakdown of amino acids to production of keto acids after transamination. All that is what we're talking about from the simple arc of insulin resistance, which itself is associated with obesity. We talked about fatty acid, dyslipidemia, and lipotoxicity at the pancreas for insulin secretion, right? In those beta cells, right? In those islet cells. So it goes right back to it. Is dyslipidemia, because that's why obesity, visceral fat, is a really strong risk for developing type 2 diabetes. And type 2 diabetes includes insulin resistance, and you just see the sequelae here we just talked about, lining all up perfectly well. Indeed, the systemic and brain insulin resistance appear to be linked, as papers suggest. And one of the ways you measure insulin-dependent glucose uptake is using fluorodeoxyglucose, which is not metabolized. You can measure this using what's known as positron emission tomography. So that's FDG PET. Simple way to look at glucose uptake, right? By a scanning technique. So it's non-invasive. Right? And because you're using a fluoroderivative of a deoxyglucose, you can measure the fluorescence doing the tomography. And at the same time, the glucose isn't being metabolized. So it's stable in the cell. That gives you enough time to make the measurement. Yeah. So FDG PET. Doing that kind of analysis demonstrated poor intracellular glucose with an ironic peripheral insulin action. Why is it ironic? Well, because the brain isn't really insulin dependent for glucose uptake. It's only a component of what insulin does in the central nervous system. Right? There is non-insulin dependent glucose uptake in the CNS as well. So that's why I'm calling it ironic, both at the CNS, but also at the peripheral level. Because what it leads to at the periphery, and here we're talking the huge organ systems of adipose, and what's the second one? Skeletal muscle. Right? This is where insulin resistance plays its major morbidity role in type 2 diabetes. Those are major organ systems, and which are highly insulin dependent glucose uptake. That is sensu stricta what we're talking about when we talk about insulin dependent glucose uptake, and indeed insulin resistance when it occurs with type 2 diabetes. Okay, so again, why is that ironic? Because you have peripheral insulin action. That means you got insulin resistance. And what does that cause, though, is an increase in circulating glucose. But what about in the central nervous system, which really isn't insulin dependent glucose uptake? It's a component of it, but that's not how glucose is mainly brought in, right? Certainly there's no problem getting past the BBB, and there's no problem getting into the cells because there's different GLUT, that is glucose transporters, that are not insulin dependent in the CNS. So it's all rather ironic because you got a lot of glucose, but it's not being metabolized in the CNS, right? That's why I call it ironic. My word, not the author's. Yeah. And that may affect dementia risk due to glucose neurotoxicity. So there's too much glucose. Now, that doesn't mean the glucose is being taken up necessarily by the neuron. Maybe the glucose is being taken up by microglia. And the microglia become activated and induce what? Inflammation, because of what? Production of pro-inflammatory cytokines and reactive oxygen species associated icosanoids, generating an inflammatory response to localized nuclei in the central nervous system. Those associated with the readout of the neuropsychiatric disease known as Alzheimer's disease, or generally the readout being simple dementia. Okay. See how that works? Okay. You also get, of course, the accumulation of advanced glycation end products. That includes glycosylated hemoglobin, right? But also the amino terminus of many proteins can become glycosylated when there's sufficient amount of free circulating glucose. And what that does when you get an N-terminal glycosylation of an enzyme is you're going to modify the activity of the enzyme or transporter or receptor. And yeah, that's going to wreak overall terrible havoc and therefore damage, and then compounded by the inflammatory response in the central nervous system, leading to sometimes the very unfortunate pathopsychological disorder known generally as dementia. Now, there's another hypothesis that highlights, and we always try to give all points of view here that are at least research scientifically relevant, right? Not just scientifically, which doesn't have really any boundary. Here we talk about research science, right? Which is something that is always being worked on, never established. Never established. So another hypothesis highlights the role of microvascular dysfunction, which leads to the inflammatory response and other immune responses. By that, I mean chemotaxis. By that, I mean alterations of bioenergetics within immune cells, but then in association with the interaction of the immune response through toll-like receptors in non-immune cells, and subcellularly in cells like neurons, and indeed even microglia, which are sensu stricto immune cells. But other glia also can be affected, like astrocytes. Okay. Anyways, all that can affect dementia risk and oxidative stress, because you get increased blood-brain permeability from this potential microvascular dysfunction, and that will alter blood flow regulation, which can include aspects of hypertension, and then decreases or at least interruptions in the flow of serum glucose into the central nervous system neuronal nuclei, thus corrupting normal metabolism, and upon corrupting normal metabolism with an inflammatory response is going to corrupt the neuropsychiatric state. So episodes of hypoglycemia, which can occur from episodic insulin resistance, and particularly that's going to be associated with T2D, especially when you're starting to use insulin as a pharmacotherapy, right? Because you're going to get an increase and a decrease in glucose uptake upon insulin getting into circulation, coveting that really important insulin induced glucose uptake, and then losing that balance because of insulin's resistance. You need to get another injection of insulin, which means you're going to get this sort of Ferris wheel response, I call it, where you're at the bottom of the Ferris wheel, and then you go up and you have high insulin sensitivity, and then you go down and you have insulin resistance. You go back up to insulin sensitivity, and that's because you're titrating the receptor with the injectable insulin. That's what happens. You have episodes of hypoglycemia, and therefore there might that episodic change in increases and decreases in glucose. It also appears to be that flux rate appears to be giving you an increased risk at the hazards ratio level of dementia. So the pathophysiological changes in dementia unfold over a very long period of time, as I'm sure now you are beginning to appreciate, and how diabetes in early and midlife contributes to those processes, which you know is going to be major contribution, because I just explained it to you at the pathobiochemical level. And all those processes involve switching to, ultimately, fatty acid oxidation as the source of bioenergetics. Now, using fatty acids as a source of oxidizable substrate, it's going to bring on this entire locus of hydroperoxy fatty acid production in the membranes, the disruption of membrane fluidity, the alteration of voltage-gated channel sensitivity, and the inward or outward flux of really important ions like potassium, sodium chloride, and also the bulk movement of calcium, both extracellular to intracellular and also from intracellular stores, is all going to lead to major changes in the polarization of the membrane, and therefore what? Action potential and neural transmission. And an interruption of all of that is bad enough, but a corruption of the tonicity of that relative to activation kinetics linked to neurotransmissions such as stimuli will corrupt the system and lead to a breakdown of what is measured again at the very large cumulative level of CNS output, which are things like personality and memory, hence dementia. Okay. All right. So I think I'll go through this page and then I'm going to stop today because I think that the synthesis is probably interesting to you. It's interesting to me because I put it together and I've read these papers, and I think there's a lot here we can discuss as I've been doing in the marginalia, the biochemical marginalia, on the, in the margins. So, as the authors tell us, the strengths of their study included the precise measurement of diabetes from midlife to old age because they had a huge cohort, and they also did a pretty good follow-up for dementia. But also the study had limitations, including a failure to discriminate different dementia subtypes, because there are many, as I've been describing to you. There's prefrontal dementia, which doesn't necessarily mean Alzheimer's disease involvement. That includes A beta and tau protein. Okay? Forget about plaque formation in the brain. It can involve all kinds of other subtleties. Dementia can, and we've measured this in the mirroring models with knockouts and whatnot, and superinduction. And remember the steroid desaturase story with problems with neuropsychiatric conditions. Remember those? That's right. And what was that linked to? The ratios of saturated to unsaturated fatty acids found as either amide linkages on sphingolipids such as ceramide, versus those same fatty acids found in phosphoglycerolipids, including that subclass phosphanolipids, which are those ether-linked lipids. Remember all that? That's all from my, you don't remember it because you haven't been listening to the Authentic Biochemistry audio podcast. After all, there were 9 lectures. Each lecture is a half an hour, so that's quite a number of hours of lecture that you're totally missing out on unless you go to the podcast. Subscribe, and yes, please make a nice, healthy donation. I know times are hard, but I also know that from the people that are listening to this podcast, I do believe you're gaining some really good, not just information, but I believe good evidentiary-based knowledge about what goes on in the research science literature, as me as your guide to go through it and explain it to you. Yeah. So sorry for that plug, but I had to do it. The producer said so, and because I'm the producer, you know what I'm saying. All right. Now, participants in longitudinal studies tend to be healthier than the general population. Why is that? Because they're constantly being monitored and they're meeting up with their clinician. So the doc says, "How you doing, Fred?" And Fred says, "Well, I'm doing fine." The doc says, "Wait a minute, it looks like you gained a little bit of weight. Or it looks like you got some unusual coloration in your eyes. Or it looks like, maybe when I checked your reflexes, they weren't quite that good anymore." Remember, dealing with older population, these things do, obtain without a lot of exercise and controlling your diet. That happens at a higher frequency, right? So people that are regularly in a population being studied are going to be healthier, just the way it works. It's a statistic that's well known in the clinical medical literature. Now, the rates of diabetes, 16.5%, dementia, 6.3%, according to what these researchers were able to dig out of their UK data, is lower than the general population in that country. This was a UK study, remember? So that once again suggests that these people are more interested in their health and more interested in their health. So does this really fit to, right, migrate according to this cohort study to the general population? I think I can say pretty clearly it isn't a direct correlation. So the risk ratios that you try to make that huge induction about, and then odds ratios and hazards ratios, which I'm going to talk about in the next lecture in more detail, don't necessarily fit the general population. And because of that, is this exactly what you find if you took a core sample from the general population that weren't otherwise being regularly tested at the clinic? Very important point. Data on glycated hemoglobin, which is usually for measurement of type 2 diabetes, type 1 and 2 for that matter. Type 3 also, remember type 3, is a more stable marker of diabetes, and that was available only in the later studies because they could not be used for diabetes diagnosis, and I agree with that. Okay, I agree with that. It can't really be the only thing measured because glycated hemoglobin is an after effect of high circulating hyperglycemia, right? And there's a lot of other factors that play that role, and a lot of other factors are going to limit that and limit that end linked glycation, particularly with hemoglobin. So dementia ascertainment was based on a linkage to electronic health records, and that also is a huge limitation rather than in-person screening. So they weren't actually putting these people through any kind of psychiatric testing for memory, looking at actual dementia scores, right? This is based more on electronic health records, which of course is data, but whether or not that data has the full complement to be called evidence, it's hard to say. Probably not, right? So the age of the participants, the end of the follow-up, up to 69 to 89 years, it's a good 20-year span for the elderly, implies that the younger participants have not yet reached an age when dementia is more prevalent. And clearly, we know this from the general population. So the synthesis of this paper is the following. In a longitudinal cohort study with a median follow-up of over 30 years, this is in the United Kingdom, the younger age at onset of T2D, type 2 diabetes, which is obesity-linked, was significantly, according to all their statistics, associated with a higher risk of subsequent dementia. Okay? So that's a very significant bit of information, even given the caveats of the study. Because on top of everything else, on top of all the somatic diseases that we here at Authentic Biochemistry have been talking about, me personally as a professor of biochemistry since the early 1990s, that obesity, whether or not there's an involvement of diabetes, often there is, but whether or not obesity is a major morbidity linked to premature aging and high morbidity, high mortality disease, including those linked to inflammatory diseases, and diabetes is one of those. And obesity itself triggers, because of dyslipidemia, massive amounts of chronic hyperinflammation. Okay, so that's the take-home message for today. I don't know how long we've been doing it because I haven't been running my ticker, the time ticker that is, but I assume that we're close to the hour mark anyway. Okay, and I'm getting a little bit tired, and I almost want to apologize for having Rocky, that's my dog. I had to let him out. I had to leave, but I'm not going to apologize. I'll just remind you that, that's why we need more. That's why we need more support in terms of financial support. Because if I could get help doing this, I would, of course, accept volunteers, but volunteers coming to some remote location to be able to help in the studio is one thing, but that would be fine if we could find out how to do that. But more importantly, just being able to, provide some income for this overall operation is really essential, especially in these harder times when I'm trying to keep up with the amount of volume I'd like to produce. I'd like to produce something either on video or audio every day, including Saturdays and Sundays. But it takes a lot of effort to put this together, and it takes me away from other things. So I have to be able to find some kind of monetary compensation for it, and that's what I'm asking for. So help out your old doc here, and please consider contributing what you can. And I know that it's hard. So I'm going to end this podcast by first closing that off and then going to that page. Gee, I'm getting better with this. You'd think I would after 3 years. And what I want to say is we are at a point um, in the diabetic discussion that I'm going to do maybe another audio or two lecture, but I've got a lot more to do with the video because I put together a very large video lecture on diabetes. And we only got up to slide, what is that, 11? And I have a lot more slides than that, as you can see. I'm not going to run through all of them, obviously. But I'm going to figure that we're going to do 2 or 3 video lectures before we go back to audio. So for those of you that like video lectures, these YouTube things, ensembles, then there you go. I like doing them because it makes me feel like there's more of an interaction, even though I'm only talking into my HD camera. I like to do them because I do feel like it allows you to have more personal touch. And also, I do more, I think, on the margins and in the margins to describe things like I do in open lecture hall. So you get that experience, hopefully, a little bit more at a pure level than you do with the audio. So this is Dr. Dan Guerra from Authentic Biochemistry Studios in the Inland Pacific Northwest of the USA on this, the 13th of March, 2022, a Sunday afternoon in Lent, saying bye for now.